So, sir, once again,
Recording चालू मत करो.
all right.
Okay.
So, yes. So, I request the attention of the faculties and delegates, and I will take few minutes of yours and let me introduce me and the faculty members. So, good evening and welcome to one and all. I'm Ankita from Planet, the designated session assistant for a seamless experience. And Planet is India's most trusted and widely used tech platform with multiple enriching services exclusively for doctors. Planet is very proud to be a digital partner for this event organized by Indian Society of Anesthesiologists, Maharashtra. And topic of today's session is communication and documentation. And let's begin today's session, for which I would like to invite Dr. Avinash sir to take over. So without any further delay, sir, please proceed. Over to you, sir.
Thank you, Ankita. Can you hear me?
Yes,
Hello?
sir, perfect.
Yes. Good evening, everybody.
Good evening.
I welcome on behalf of Maharashtra State Chapter of Indian Society of Anesthesiologists for this MSCISA Symposium 7th. You must have heard and discussed too much on the medical legal cases, but today we will have a topic, communication and documentation in anesthesia practice. Proper communication will prevent, while perfect documentation will protect you from the negligence claims. It was believed that communication skills are something that one is born with, but it is not a reality. It is a skill that can be taught and improved upon. It is not given explicitly in our textbooks and was not taught formally to the students of anesthesia until recently. Anesthesiologists are expected to communicate effectively with patients, their families, colleagues, and from the medical fraternity also. Effective communication is seen to improve health outcome, patient satisfaction. It reduces the errors, misunderstanding, distress, and negligence claims. Anesthesia documentation represents a detailed account of patient anesthesia care during various phases of anesthesia, that is pre-op, intra-op, and post-op. Accurate and thorough documentation is an essential element of high quality and safe medical care. Documentation of anesthesia care is transitioning from the handwritten record to an automated electric medical record. Communication, documentation, communication of documentations, and documentation of communication all play important role in this medical legal era of medical practice. Let us learn all about these from our eminent speakers and chairpersons. Thank you. I hand over this to Dr. Charuta Gadkari, madam.
Good evening, everybody. A warm welcome to all of you on this platform. Today, Dr. Sare sir is not joining the webinar. So it is my privilege to welcome you all here.
As a
Communication.
Yes.
Yeah. I'm the vice president, and in absence of President sir, I'm just welcoming you all. Communication and documentation are very important to any clinician, isn't it? Anesthesiologist is no exception. Communication skills of anesthesiologists make an important quality for successful career. We communicate not only with patients, but with surgeons, with physicians, OT staff, our peers, juniors. So good communication keeps us relaxed. And documentation is the key to safe practice of anesthesia. Though we are not actually with an advanced stage of electronic medical record, and we are not even enthusiastic and thorough in maintaining manual record, there is no shortcut to good record keeping. Good documentation keeps us very safe. Today's webinar has two very senior anesthesiologists who will deliberate on these important topics. I welcome Dr. Satish Kulkarni and Dr. Pratibha Kane on this platform as speakers. Chairpersons, Dr. Venkatgiri sir and Dr. Kalpana Kelkar madam, again are stalwarts from our field, and I welcome them to this webinar as well. I have a pleasant task given by our secretary to introduce Dr. Venkatgiri sir to you. So let me begin. Very illustrious CV, I must say. President of ISA National 21-22 and Academic Chairman of ISA National 22-23, President of SARC Association of Anesthesiologists 23-24, and President of the Organized Medicine Academic Guild of India 22-23. Dr. Venkatgiri sir needs no introduction actually to this gathering. He has been very popular as Honorary Secretary of ISA National. At present, he is working as Senior Consultant in Anesthesia at General Hospital, Kasaragod, Kerala Health Service. He has been Secretary and President of ISA Kerala and, of course, ISA Kasaragod. He has been actively involved with IMA and has been past Joint Secretary as well as Vice President of IMA Kerala. He has been invited speaker at many state, zonal, national and international conferences of ISA and other associations. He has been co-author of ISA COLS guidelines. With an MBA qualification in the long list of qualifications to his credit. At present, he is Professional Wellbeing Committee member of WFSA. On behalf of ISA Maharashtra State, I welcome you, sir.
Thank you, madam. Thank you.
Welcome, sir. Thank you, Charuta Gadkari, ma'am. Now I request Dr. Manisha Katikar, madam, to introduce our next chairperson, Dr. Kalpana Kelkar, madam.
It is my proud privilege to introduce our motherly teacher, anesthesiologist, Dr. Kalpana Kelkar, madam. Madam also doesn't need introduction. We all know her. She is what I can say, a mentor to many of us, and I'm one of the privileged, though I was not lucky to be her student, but one of the privileged ISA member she has always showered love and affection and always blessed me for all whatever I think of or whatever are my whatever is my interest. Madam doesn't need introduction, but for the formal sake of this webinar, Madam is professor and head of the department Critical Care Medicine, DY Patil Medical College, Pune. She was ex-consultant and HOD Emergency Medicine, that is in KM Hospital, Pune. She is retired professor and head of the Department of Anesthesiology in BJMC, Pune. Madam is winner of many awards for best paper and poster at various conferences, has many research publications at her credit, has participated in numerous symposia, panel discussions, and has delivered many guest lectures on various regional and national platforms. She is a member of Postgraduate Board of Studies of Maharashtra University of Health Science from 2006 to 2011. She is examiner for DA, MD Anesthesia, as well as inspector and appraiser for DNB. She is past president of Pune City branch of ISA and at present executive committee member of Society of Anesthesiologists, Pune. She was governing council member of Maharashtra State Chapter ISA. She was deputy dean of BJMC from 2006 to 9. She is member of Academic College of Emergency Experts of India and governing council member of the college. She is instrumental in starting the surgical ICU and trauma center at BJMC and was in charge of trauma center at BJMC and Sassoon Hospital till her retirement. She started MUHS recognized fellowship courses in pediatric anesthesia, pain medicine, and critical care in BJMC. She guides anesthesia colleagues in medico-legal cases, member of medico-legal cell of IMA Pune, and recipient of Lifetime Achievement Award as well as Hall of Fame Award at GARP 2017. She was organizing chairperson of Anesthesia Alumni Meet in 2018, where all alumni of BJMC over 50 years had gathered, and the meeting was a huge success. And all of us know, Madam is a writer of 3 poetry books, and she is a good poet, and she has also published one set of audio CDs that recently. Welcome, Madam. It is our proud privilege to again welcome you on the prestigious dais of Maharashtra State Chapter ISA.
Thank you, Manisha.
Thank you. Thank you, Manisha, madam, and welcome, Kelkar, madam. Now, I request Dr. Balaji Asegavkar to introduce Dr. Satish Kulkarni. Balaji, are you there? No. Okay. Ankita, please. Yes, I will introduce Dr. Satish Kulkarni, sir. Is head and senior consultant, Department of Anesthesia at Lilavati Hospital and Research Center, Mumbai. he has done his DA, MD, DA in UK, FRCA. Sir is associated with Indian Society of Anesthesia, Fellow of Royal College of Anesthesia, UK, then Association of Anesthesiologists of Great Britain and Ireland, Academy of Regional Anesthesia, India, then member of and secretary and treasurer, president, ISA Mumbai branch. Welcome, sir. Now I request Dr. Samir Soni to introduce Dr. Pratibha Kane, madam.
Good evening, everybody. And another very well-known figure of ISA Maharashtra. It's my proud privilege to welcome Dr. Pratibha Kane. Ankita, please put on her slide. Yeah, thank you. She is presently working as executive committee member of Society of Anesthesiologists, Pune. She has worked as past president of ISA Pune City branch. A vast experience of 38 years as a teacher in the field of anesthesiology, presently working as HOD in the Department of Anesthesiology, Jangir Hospital, Pune. A very bright academic career, was awarded gold medal in MD anesthesia. She has also graduation in the law, LLB, with honors. She has also done masters in personal management, and she's Oxford, UK certified for healthcare communication. So the topic today we are going to discuss about communication, a very well known figure, Dr. Pratibha Kane. As we all know, she has been we have met her in various conferences and CME as faculty, and on various topics, and especially on medical legal issues and as well as anesthesia related topics. I welcome you, Dr. Pratibha madam, to this symposium today. Welcome.
Thank you, Samir.
Thank you.
And,
Thank you very
welcome,
much.
Kane, madam. Yes.
Thank you.
I-
Thank you, everybody.
I request Dr. Satish Kulkarni to deliver his lecture.
Thank you very much. Good evening to all. Kelkar Madam, Venkatagiri Sir, office bearers of the Maharashtra State Chapter of ISA. I would, and with kind permission of Dr. Kane, who I saw that she's got a master's in healthcare communication. So I'm going to speak about communication in the OT. And 1 minute, I need to share the screen, correct?
Yes, sir.
Yes, sir.
Yeah. Yeah. Are you able to see the screen now?
Yes, sir, it is visible.
Yes, sir.
Visible,
Perfect.
sir.
Perfect.
Just-
So with kind
yeah.
permission of Dr. Kane, I'm going to speak about communication in the OT room. A very warm good evening to all of you. And it's a very important topic, very less discussed. And we have a lot of, a little bit of literature about communication, not in the operation theater per se, but in acute care settings or on the ward. But otherwise, there's hardly any material or any publications on what communication in the operating theater, what are the barriers, or what are the facilitators to improve the communication. However, having said that, more is probably written or more is discussed about the barriers rather than the facilitators which can improve. So today, probably number 20-25 minutes, what I'm to speak about a little bit of communication in the OT room. What are the problems with lack of communication? What do you mean by adequate and effective communication? What are the challenges? And what sort of strategies for safer anesthesia which we can have? And if at all, if it has any impact on the anesthetist. Now, we all know with the increasing technology and increasing the science, there's a huge worldwide increase in the operative procedures. We ourselves have seen, what sort of cases what we used to have when we were training, and today the number of procedures, the number of also there's increasing recognition of errors because of the human behavior. It's said as almost about 50 to 60% of the errors which occur in the perioperative period Now we're going to talk about and restrict ourselves to the perioperative period as well, or probably intraoperative period. So they are unavoidable and they are related to the human behavior. After major surgeries, the rate of complications because of either error or probably somebody not taking adequate care is goes up to almost up to 20%. And what it occurs is basically is these adverse events really are very expensive, apart from increasing the morbidity, probably mortality to an extent, and increasing the length of stay and the cost. One of my relatives got operated about 6 months ago for a thigh sarcoma, and the wound got infected post-operatively. Probably, I don't know what happened. Probably the drain was removed early at some other hospital, but I wasn't there at that time with the. But one infection, and he was having probably WAC dressings for about 3 months, meropenem injections for about 3 months, and the cost escalated like at least 8 times than what actually it was. So the cost implications are huge, and surgical complications are a considerable cause of death, disability, and long-term disability. Now the complications arise in the surgical patients almost up to in 1 in 10 surgical patients due to errors. That's what the data says. And medical errors amount to significant number of deaths. Now, this is US data. We don't have data of our own. And of this, the Joint Commission report said that about 70% of sentinel events are because of ineffective communication, and probably root cause of the about 66% of the sentinel events. Verbal communications or lack of verbal care accounts for 92% of malpractices cases. Also, a paper in the BMJ Quality and Safety in 2004, it also mentioned about the ineffective communication, the root cause of medical errors. Yeah, and the characteristics of the whole idea of this paper was to characterize the communication failures in the OT and the effect of those failures. And they observed 48 cases, and they came to a conclusion that ineffective communication is the root cause, and that can cause. Now, they have a lot of implications. The consequences about this ineffective communication. Operation theater is a very sort of a high-stressed, high-activity, dynamic. It can almost get related to a sort of high reliability organizations, which are like nuclear power stations or aviation industry or oil and natural gas explorations. So basically, and we have a different number of teams working. There is a surgical team, the anesthesia team, probably the paramedicals are there, the technicians are there, the boys are there, and probably sometimes there are specialists from other areas which come to help us with the. So there are different number of people, all interdisciplinary worked as a one team. And if there is no effective communication, there's a lot of misunderstanding and stress involved in the. And if there is a breakdown in the communication, which can cause further damage. But again, the professional experience and the backgrounds of all these professions. So it's a mix of different expertise and qualifications which are coming together with a common goal to improve the healthcare. The implications, apart from your malpractice claims and apart from the misunderstandings and patients having these things, there are a lot of implications. We do regularly read in the newspapers about attacks. Probably this is my feeling. A lot of times the problems about this is about lack of communication or inadequate or ineffective or something communication could be there. I'm not saying it is always the thing, but because some of the patients' relatives can be very, very whimsical and they may not want to understand a few things. But yes, and this could be, but at times probably it is one of the reasons of our communication. And obviously, on a lighter note, we can see this cartoon from Ganesh saying that they are working to the remote controlled robots now because of the attack on doctors. We don't want to do these things. Now, this has not only stopped for having this for having a cartoon say. It is an actual reality. This news came up this was about 23rd of April last month. This was a month ago. Woman attacks a robo receptionist because she got very upset with something. And there was a robo in the hospital reception which used to take care of whatever, basic information and everything for the patients. So she got so upset that with a stick, she actually broke down the robo. So it is not going to be only physical, but it can be a lot of other implications. And safe time effective communication probably is very important as well for effective patient management and patient care. So what is communication? It is basically a process by which information is exchanged between individuals through a common system of verbal, medium, symbol, signs, or behavior. Essentially, it's a transfer of information from one person to another with inference of meaning. That is what communication is. And effective communication is very important that, one person says the other person understands as well. Otherwise, a lot of times my experience is when we are talking something, most of the people do not have this habit of listening to you. They just want to, they're there, but they don't listen. They're just hearing probably, but they're not understanding what this. Now, there are the whole purpose of the community is to either to inform, to control, to motivate, and to express emotions. And there are two different types of communications. Either it can be personal or organizational communication that we are not going to talk about. But communication generally will be verbal, which is probably a spoken words that, you say something to them and the other person understands or responds. It can be paraverbal as well. Paraverbal, which means by the tone or the speed of your voice or the tone that you see. And the non-verbal communication, which means that it is basically by gestures or by signs and symbols. So this is the difference between verbal and a non-verbal communication. Now, as far as our anesthesia, I'll just come to a little bit of non-verbal. This is something what we call as non-verbal by the gestures or facial expressions or body languages you try to communicate. And also, this is possible to communicate. Yes, your appearance, your body language also will matter. But these are non-verbal communications, which only basically are paraverbal, because basically without any voice, you can make out, apart from having gestures and everything at all. Now we have a lot of emojis or something that also can communicate with the sort of non-verbal communications. Having said that, in operating theaters, we don't have much role for non-verbal communication because most of us are probably wearing masks. And then probably your facial expressions, or if you make a funny face or something, if you don't like something, it may not be seen. But yes, verbal communication is probably the most important part as far as communication. So essentially, to come to the point, safe anesthesia practice calls for expertise in communication. That is what we need. It does concern to healthcare. Surgery and anesthesia could lead to severe complications. Gap in communications do cause problems and adverse events and can be a source of malpractice claims. And bridging the gap between high quality healthcare in a complex set of operating room amongst interactions among different medical teams. So that is why it's very important. Now it has to be adequate as well as effective. Now, if it is adequate, which means the transfer of information between the operating room via either verbal or normal methods, clear passing of intent, or inclusion of a straightforward content, a clear appeal to recipient, self-revelation about a sender. And so essentially, if it is not proper, which is a major contributive factor for never events such as wrong side. We know, one of the ways what we communicate, which NABH has also insisted on this thing, is probably having a surgical safety checklist, which we do. That is one of the ways of communication or standardizing the communication by having a checklist, but that has to be adequate. So essentially, adequate and the effective communication should be brief. It has to be clear and it has to be timely. Again, whatever message or information you pass on to other, it has to be understood by the recipient as well. So that appropriate, if it doesn't understand, it can be a problem. And there are various factors can be there in the operating room where it can be difficult probably. Apart from, we also see sometimes is language barriers. Now in a country like ours, where people can this thing. So this is a small video. This is probably a first year resident or a first month RMO. So this was one of the things to effect for having a language barriers. However, there can be lot more barriers in the operating room. There can be hierarchical errors or distractions. So which can hamper effective communication. Now, what are the challenges which we have in the operating room? Some of the challenges which I have this thing is one, noise levels. Hierarchy is one of the very, very important obstacle to challenging an unethical decision and having a proper communication. Because we have probably personnel in the theater which comes from different backgrounds, from different ethnic backgrounds, different educational backgrounds, different socio-economic backgrounds, different educational levels, and some of the egos as well come into the picture. There can be conflicts within the OT teams. Anesthetic is saying we cannot do the case because the patient is not adequately fasting, or something, we need an echocardiogram, or we should not be doing this case. And then a lot of conflicts do occur. But probably a lot of these can be solved with the areas. But these are the challenges which we see day in and day. Also, anesthesia screen as well can be a probably. That is, I'll come to that a bit later. But what I'm a little bit worried about, and I'm also getting a little bit concerned, is about the noise in the operating room, in the theaters. Traditionally, if you look at in the 70s and before, operation theaters and the hospitals were supposed to be a sort of having a calm and a serene environment. And there used to be, I still remember the boards outside the hospitals having a silent zone boards, but it's no longer the situation now. You see the operating theaters are so noisy, and worse than that are the recovery areas and the critical care units. There are alarms going on. There are multiple reasons. I'll come to that in a bit later. So these could be one of the challenges in the communication. Again, as I said, hospital theater environment is a high stress environment. There is a time pressures. It's hierarchical, probably surgeon dominated. Nursing staffs can be voiceless. There can be tensions. And most of in our setups, we try telling something. It is always looked at as theory rather than actually practical. There can be egos as well. You might have surgeons which probably would assume, or somebody else also can assume that they know best, and it cannot be challenged. So this is one of the videos regarding yeah, this was the lighthouse, and probably they were asking him to. This is just basically one video which I thought was nice to show, how the egos can come into these things, and that can cause a lot of communication problems. As I was coming down to the loud noise, operating theaters were supposed to be quiet. We only see them probably in the movies now, that how quiet zones and how serene environment is in the hospitals. But otherwise, hospitals are so noisy, especially the OTs, the critical care units, the recovery areas. There are a lot of criteria set down by occupational health organizations where they say should not be more than 55 decibels. But on an average in an operating room, it's more than 85 decibels on an average, and at times it goes to more than 120 decibels. Out of that, 50% of the noise level is because of the irrelevant small talk, or which is not related to the patient care. Now, it's extremely irritating if you have this noise, which at the time of induction or at the time of reversal. And so that can really, really cause a lot of communication failures and gaps. Other important sources of noise in the operation theater, which can have a huge impact on the communication issues, is your instruments. Those power drills, your air warmers, your laminar flows, your metallic instruments, clinging of the, while you are inducing, the sisters are trying to get their trolley sorted out. There's a lot of talk going on, somebody trying to explain something. The instruments are clinging against each other, and if by chance, if the trolley topples, then you can have sort of, it can go up to 200 decibels also. And all these equipments and all those things, for you, even simple things like warmers, your alarms, music is one other source of these things. I mean, it is a very controversial thing whether music actually is good, bad, or these things. It all depends on multiple factors to and that situation. A very pleasant, soothing music might be probably helpful in calming the minds, but at times it does just contribute to your noise pollution and your noise levels in the theaters. Again, your distractions are also there. Small talks, they're talking something else about while the case is going on, phones, pagers, people entering the theater, going into the theater. Those also can contribute tremendously to your distractions and lower and having communication gaps. There was one study which showed the screen. Most of us probably put up a screen once the patient, everything is draped and everything at all, so that there is from say whatever, there's a barrier between the head end and the operating room. We do call them blood-brain barrier, but however, there's one study which showed that the moment that this thing is going on, patient relevant talks go down and irrelevant talks probably come up in a much higher noise, higher level of noise levels. But otherwise, patient relevant talks go down the moment the screen goes up. So a simple thing like a barrier also can cause a communication gaps. This is what the study which I was talking about. So he studied basically by putting these things, and he showed that the moment screen is this thing. Wait. Again, I did mention about the hierarchy. They did a study where year 2 to year 5 postgraduate students. This was a simulation study where the postgraduate students, and it was like a sort of simulated role play where second year to fifth year postgraduate students were given a scenario, and they did show that that as your number of years increase, your hierarchy goes down. So a department which has an open policy or open sort of atmosphere where junior levels or any other staff is able to openly discuss things or openly are able to communicate their concerns, there the communication gaps are much less and patients tend to do better rather than having a hierarchical approach where people might be scared to speak up or open up. Conflicts with an operating, I mean, everybody working in the high positions and the high pressures. Yes, anesthesia might have their own reasons for the conflicts. There might be different professional views, and it does happen day in and day out. But however, having a calm mind and discussing the problem in a calm manner and probably sorting out a solution to it can have easy effect. And sometimes the patient had taken milk, the surgeon is saying that probably he's had milk, we cannot wait for 6 hours. The surgeon says liquid, I can't do it in 4 hours. You can always speak about and everything, and it does sort out a few things. A lot will depend on the personal trait. Again, your shortage of work facilities, shortage of staff, your stress, your sleep deprivation can also contribute to your conflicts. So we know all these sort of noise levels, conflicts, hierarchical pattern, the way system works, organizational issues, multiple factors can cause a gap in the communication and kind of problems. So what are the strategies? What are the strategies we can have to improve the safety and have effective communication? One is, yes, standardized protocols. Because the moment you have standardized protocols, suppose we have standardized protocols, it will improve the communication. There can be training is going to be the most important, and there are different ways of communicating, like closed loop communication, which I'll come to in a bit, and obviously noise reduction strategies. Communication training. Now, our specialty or a medical specialty as a whole has not yet, compared to your aviation industry, where they get regular CRM, so-called crisis resource management, whether you call it crew resource management or cabin resource management, they have regular training about communication failure. We have, in fact, of all the medical faculties, the anesthesia is the one who has actually taken this safety issue in a very serious ways, and we are working towards improving the communication. So much so that even in the DNB, some of you might be DNB teachers and examiners as well. So there, as one of the spot in the exam is about communication skills, and it has to be the part of training. So having this sort of role plays, interactive participation, simulation areas, where training can be accomplished regarding communication about various aspects. Now, obviously, it's not the same patients every time and the same thing, but certain things are common. So what is basically what you need to effectively communicate in all scenarios by giving a correct message, clear message, complete message, precise message, and so sender should understand that as well. So there are some standards of effective communication. Again, as I said, it has to be complete, clear, brief, and timely. This is one of the things is having a checklist. So that actually standardizes a lot of things. Now you might have said the surgical timeout. The moment you do a surgical timeout, all of them do at one go. We do check a lot of things. So chance of it, whether it's an antibiotic is given or not, whether the side is correct or not. So all those three of the things get communicated. Also, what happens is that when all of them are on the same page, there's a shared mental model. So all of them understand what the problems are and what is to be sorted out, whether the antibiotic is given or not, and they're probably are on the same page. So that will improve the communication tremendously. And it's very simple to do the safety checklist. The only problem is that though the safety checklist doesn't say that who should be doing it and how it should be done and at what level. So that are some of the bad, but it's a very simple thing, and it has shown that by having a simple checklist, there's a reduction in the morbidity by almost 38 to 40%, and the wrong side procedures and the never do events have tremendously gone down. This is another safety checklist we have at our hospital, is a pre-operative safety checklist. When the patient gets transferred from the ward to the theater, they pay, apart from the patient name and everything at all, there's a checklist where the hemodynamics are noted, where the allergies are noted, the blood products, whether they have been cross-matched, how many, all those same skin preparation, the NVM status, the consent forms, personal belongings, the investigation reports, all, the ward staff hands over to the recovery or the theater staff. And while going back to the ward also, all this is some sort of checked and this thing. So simple having a sort of checklist, it can improve the. Now this checklist is before the procedure. Even for handing over to the ICU or to the back to the, they can have similar sort of checklist. I'll come to that in a minute. So there are various ways of how effectively you can communicate, and one of them is called SBAR, which is contains the situation, background, assessment. This is one of the methods of communicating, which is as a part of the CRM protocol, which is traded. So it basically provides a framework team members effectively communicate. And the situation, it is what is going on with the patient, background, assessment, and recommendation. For example, if it is, I've seen a patient on the ward and I said, I am with Mrs. So-and-so on 8B, posted for lab police tomorrow, doing a pre-op assessment as per your request. So I'm communicating with the surgeon. The background is she's obese, the hypertensive, and BP of so-and-so, multiple misbeats, and a diabetic with a pain score of 7. Now your assessment, I have secured an IV line, given paracetamol, and your recommendation is, my opinion, we should get a 2D echo, get a cardio reference to optimize it and post-op for surgery. Do you have anything to ask more? So this is probably a sort of SBAR pattern, which is discussed and which is teaching. This is one of the ways of, there are other ways also, but this is one of the very standard ways where the communication, effective communication can be made. Also, there's something called closed loop communication, which is the most simple and the most effective way of communicating. Closed loop communication means if I tell something to one, the other person responds back to confirm, and after doing that, confirm that it's been done. For example, if I tell my student that, can you drop 0.2 milligram of atropine or 0.2 milligram of glycopyrrolate and give it to the patient? He said, okay, I'm going to drop 0.2 milligrams of glycopyrrolate and I'm given, and I've given the glycopyrrolate. So the sender verifies. So this completes the loop. Now, this is a very standard way of communicating into the US. It has come from the US Navy, and in the Army or the aviation industry and in the military services. And it is extremely effective, cheap, and it effective. So a closed loop communication and checklist can actually improve the communication skills tremendously. And as I said, closed loop is the most amenable, simple, and cost-effective communication strategy, which has shown, though no studies are done into our theater environment, these studies are with the aviation industry, and it seems to be very, very effective way of reducing. Again, as I said, surgical checklist, increases familiarity among OT members. They come on the same shared mental space, improve communication, detect potential hazards, and reduce the incidence of surgical complications. There is enough data about this checklist and improving. There's something called assertive communication as well. That, you know, if somebody is this unfortunately is very difficult to do unless if you have a hierarchical system, because something if you are not comfortable about, you should be able to speak up. And obviously, that assertive communication should not be very in an aggressive way or in an offensive way. But, you know, you should be able to make it a point to saying that, look, I am concerned, I am uncomfortable. This is a safety issue. I am not happy with it or something of that sort. And the other person should respond either effectively. So that can actually reduce the amount of gaps in the communication. I did mention about the noise levels and how it can be removed. One study did show that, you know, by reducing the noise, improved the anesthesiologist's perceived ability to perform in the where this study was done. And one of the ways of this thing is behavioral changes. You probably can behavioral changes, having certain ground rules set in, and also by probably, you know, a lot of instruments can be the bowls and everything need not be now the steel bowls. There are a lot of good, very plastic bowls which are available, colorful, you know, which they take for some different things. Like local anesthetic, we have a small blue colored bowl. So whatever local anesthetic is given, they always take in that bowl. So that reduces the errors as well. And this. Also, this communication or the noise reductions is extremely important, as I said, at the time of induction and at the reversal. Now, the aviation industry has something called as a sterile cockpit concept. The below 10,000 levels, below 10,000 feet, the moment they come below 10,000 feet, they are not allowed to have any sort of irrelevant talks or communication apart from concentrated, which is necessary for the job. So probably we could have that, because while you are inducing, the amount of irrelevant talk goes around can be very, very distracting. Actually, I get very, very disturbed by this, and most of the people know that whenever I'm in the theater, they should be keeping quiet for the induction. After induction, I'm okay with it. But while inducing, I'm trying to talk to the patient, trying to explain something, what is going to happen. You're going to go off to sleep now. I'm going to put an IV cannula. And these people, either the surgical team is trying to put on the MRIs, X-rays, discussing about some other patient, staff nurses, their instrument noises, the alarms are going on. So, you know, something like that, saying that reducing the noise. So the behavioral modifications can be important. Also the handoffs. The communication is very important when you're handing over the patients, especially to ICU or something. There the checklists are going to be very important. However, different surgeries probably be different. It's very easy to have a standard checklist for handovers for one type of surgery. For example, post-cardiac surgery. Post-cardiac surgery, they can have a very good checklist where what sort of handovers, whether how much blood has been given, what was the bypass time, what was the XYZ, when was the last dose of heparin, and when was the last dose of antibiotic given. So all sorts of things can be, you know, have a very standardized. But having that to same for hernia, same that for some other surgery, or same for cholecystectomy or laparoscopy, it can be a bit different. But yes, you have some sort of standard, especially about antibiotics, whether about blood products given or not, whether any other issues, concerns, whether the patient has got a hearing aid, he's deaf in one ear, he is not able to, you know, all those sort of small informations are very, very important at the handoffs. And we have seen some of the videos while, you know, we are variants in Olympics. A simple mistakes in handoffs can have disastrous complications. I remember somebody mentioning about somebody put in a noradrenaline because they didn't have infusion pumps. This was a few years ago. I heard this story that put up noradrenaline in the infusion and it was not handed over or not labeled. And then there was a lot of issues occurring after, and a young patient had to have a lot of problems because of that. So handoffs are going to be very important. So you can have established handover protocols, whether you are shifting back to the ward or basically the ICU. And so SBAR type of sort of situation background assessments can have reduction in the errors as well as in antibiotic delays. And so essentially, apart from having these things, you know, you need to follow guidelines and adopt training programs. Now, it has to be a part of our training schedule. For most of the societies, whether it's an American society or crisis research management training, they all stress heavily on how to go about to deal with the conflicts, to deal with the communication. And that has to be incorporated in our practice as well as training. Interdisciplinary team training programs also in the healthcare workers, which encourage teamwork, will also improve the communication. But the most important is the last one, the time taken off from work at regular intervals does improve, remove the person from a stressful work environment, does help them to rejuvenate both physically and psychologically. And this thing, after going from a holiday and coming back from a nice long holiday, you do feel a little bit of better for a few days more. And then, you are trying to, you are in a much best of your mental state to communicate. And there is a communication is much better. So it is very, very important to take time off from your regular work intervals as well. So I would like to stop here and like to conclude that operating room is a busy environment with multiple opportunities for quality communication. It is a high stress environment, time pressured, with different professionals from different backgrounds are working, different teams are working. There are paramedical staffs from various different backgrounds, educational, ethnic, socioeconomic. There can be barriers, and identifying those obstacles in communication and managing them post-strategy will improve the satisfaction. Ultimately, it is a teamwork. And if you do not have a very good communication, there are bound to be problems. And effective communication, as I said before, fortunately, DNBs and all those sort of professional bodies which are involved in the training of the people have realized these issues about lack of communication, and they have incorporated this communication training in the training as well, and as a part of the exam as well. I would like to stop here and thank you very much for your listening to the talk.
Thank you very much, sir. You have pointed out very small things in OT. It is like a musical orchestra going on in the operation theater.
Yes, I agree completely. You are never right, unfortunately, but we try our best to at least look at the various areas where distractions, your noise levels, your communications can be improved. It is possible. It's not something it is impossible to do. But yeah, certain areas we can definitely improve and try to do our best as much as we can.
Yes, thank you. Venkatgiri sir. Hello. Yes, Kalpana Kekar madam.
Yeah.
Yes, sir. Yes, Bhosle sir.
Yes,
Yes.
yes, sir. You want to discuss some? You want to give some inputs in this?
No, his talk is exhaustive, and with the Dr. Satish Kulin this much exhaustive and detailed talk, I don't think anything we have to add. But what is more important is we have to learn what is important and learn from them. See, many things we may think it is not important and very small, but all these things are very much. He has put even the small and comparing with the cockpit and all. So we should, and more classes and more people should hear that. Then only we will understand the each importance. Otherwise, we will not have the know why this is important. He was telling that because I was also not caring that maybe from now we have to think that during induction and this thing should be very quiet. So because we from IS also we are doing that communication skills for the members. Different people talk in a different aspect because we have heard from Meenakshi, we have heard from now from Dr. Satish Kulkarni and others also. All together, I was even telling that we should have workshop on communication skill and people should have that. And it is really exhaustive. And if you have any doubt, we can have it afterwards. He has taken much pain in preparing, and he has dealt it so well that it was pleasure to hear him in this.
Thank you very much.
Thank
Sir.
you, sir.
Thank you, sir.
Really
Hello?
Madam, please.
Yeah, it was a really exhaustive discussion, Dr. Kulkarni. He has covered lots of
Madam,
things,
thank you.
but I think one important aspect has been left out, and that is communication with the patient. I think the anesthesiologist has to get introduced to the patient beforehand, and from the busy schedule, we have to find time to talk to the patient, because that is what is lacking these days. And he has to be informed about what is exactly you mentioned in your talk, that you talk to your patients, that you are taking an IV line. Of course, all those things are important, but I feel that in today's busy work schedule, what is missing is the appropriate communication with the patient, and that can increase even the legality, medical legal implications also. And when the patient is being shifted, or even beforehand, the patient should be given clear idea of what he is going to expect in the post-operative period. So then he's well prepared. I think that part should be added to your exhaustive talk.
Yeah, madam, I completely agree. My talk mainly was focused about the intraoperative interpersonal communication.
Yes. Yes.
And we do see all our patients preoperatively, and they're all explained about all the anesthesia modalities, as well as what their choices are, about the pain management protocol, whatever, they would these things. I
No,
completely
because
agree.
I
But
think the communication with the
Yes.
patient, I'm not saying that you are not doing it, but I'm trying to
I understand,
impress
madam.
on the patients who are listening, on the listeners who are listening to this, that the good communication on our part can decrease our medical legal burden also.
Yes.
I mean, and that period, the perioperative period, the patient is so stressed, and for us it can be a day-to-day experience of going to the OT and anesthetizing, but for the patient it is a
It's
lifetime
only a
experience.
once in a lifetime. I
So,
completely
so that is extremely important, that we have to teach our students that they have to be sympathetic, they have to explain things, even though they might get tired of it, but you have to do it.
Even
Thank you.
even self introduction is also important.
Yes, yes.
Our name and
We have to come to the
yes,
forefront and explain what you are going to do. Yes.
yes. Okay, thank you, madam. We'll go to next lecture. I request Dr.
But
Pratibha
otherwise,
Kamala.
it was a really a learning experience for everybody, I think.
Thank you, madam.
Yeah. Okay. Thank you, sir.
Shall I share
We'll
my
proceed to
screen?
next lecture. Yes, ma'am. Please share your slides.
Can you see my slides?
Yes, 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 ma'am.
Yes, yes.
Please continue.
Okay, I thank all the office bearers of the ISA for this invitation. And with the permission of Dr. Kirkar and Dr. Venkatgiri, I will start my topic, which is documentation in anesthesia practice, which is the most neglected part of our anesthesia practice. And we are also enamored by learning new skills and new knowledge. We totally ignore the skill of documentation. It usually goes like this, that we finish a case and it is time to go, or you want a break, but the documentation is pending. And then what we would naturally do is delegate it to our juniors, ignore it for the time being, or say that we will complete it later, which may not happen. And it is not surprising that around 60 or more than 60% of cases that go against doctors are for improper documentation or improper consent, which is also a part of documentation. In spite of this, documentation is not taught formally, and it is not a part of any medical curriculum. In 2020, the Justice Indu Malhotra was invited for a very prestigious medical legal conference, and she was asked about medical negligence cases, and she advised doctors to do robust documentation. She did not say, look after your patients. So we have to kind of learn this science with the objective of creating a clear understanding when our documents are scrutinized by a third party. And let me emphasize that it is every doctor's ethical and legal duty to create a document of which is an evidence of continuity of care. And the responsibility of the content is entirely on the treating physicians. So we cannot say that our residents wrote it or my junior wrote it. So the responsibility of the document is entirely the treating physicians. So documentation today has much more value than just a treatment and its progress. It is absolutely essential for healthcare delivery and for its efficiency. So these are called Alfred values. And so A stands for administrative value, which is the identity of the patient, the IP number and stuff like that. Legal value, we will elaborate in the due course of this talk. Financial value, the billing and insurance claims. So the US has gone to such levels to ensure documentation. What they have said that if you bill for a central line, but your documents do not show that you have inserted a central line, the insurance claim will not be passed. Research value, that means all good research requires robust documentation. We all know what happens when the data or the documentation is unreliable. It throws the research totally off balance. It also documents have an educational value that is required for training and to follow for better patient outcomes. And it is absolutely necessary for as an evidence of improving standard of care and quality compliance, which is required nowadays by all NABH-enabled institutions. So if we look at what our anesthesia-related document would be, so that would start with a patient declaration, a pre-anesthesia consultation document, which contains all the comorbidities, the ASA grading, your plan of anesthesia, a separate anesthesia consent, which documents the risks that were disclosed, perioperative anesthesia record, which highlights the monitors used, because that shows the care and the caution that you are taking, and a 5-minute update of vital parameters. Post-operatively, it is always better to use an objective tool for discharge criteria like the Aldrich score, so you can document it for safe discharge. Transfer documentation, Dr. Kulkarni has already talked about this, but let me tell you that transfers to higher centers are really tense situations with uncertainty. Anesthesiologists should always accompany, and there should be a formal handover, like Dr. Kulkarni said, with a Sabra tool. Now, a good clinical content would, I mean, we can always say that probably a patient or a lawyer will read these notes at some point, and we must see that they are clearly written, they are understandable. The handwriting should be good, and short forms which are not standard should not be used. Now, there is something which is called contemporaneous, which means that while you're doing an act or treating a patient, you're obviously not going to be able to write records. So the write-up of clinical records should be as soon as possible after an event or an intervention in order to ensure that it is accurate and clear. It should be objective. That means all the clinical records should be factual. And also we have to say who it is attributed to. So who has given the information? Is it the patient or the relative? All documentation should be up to date, and each entry is expected to be legibly signed with the date and time. What about amendments to the original? Ideally, the original note should not be retrospectively amended. And if you want to correct, then do not obliterate the original. Instead, draw a single line through it and just add the correction and again put your date, time, and signature. Now, tampering, removal, substitution to improve the quality or credibility of the original for deception and deceit is a criminal offense. So let us look at some case laws which are related to documentation. So the first is a classic, no documentation, no defense. So this, the facts of this case are 2004 in Vizag, an IND was done for an anorectal abscess under GA. It was properly managed for septicemia. It was the patient was sent to a higher center and the outcome was good. The patient never had any complaints about negligence. Patient said that very expensive medicines were given unnecessarily, which cost him more than 4 lakhs of rupees at that time. But on investigation, the National Commission found that there was no record to the treatment given by the complainant, to the treatment given to the complainant by the doctors. And the explanation in defense, the doctors said that it was an emergency case, so no case sheet was maintained. So this was not accepted at all. And there was no record of surgery, there was no anesthesia record, there was no ICU record. And the petitioners were held, the doctor, the surgeon, and the hospital were held liable for deficiency of services, and 1 lakh was awarded to the complainant with 25,000 as litigation costs. Now, this I would like to first bring to your notice is this happened in 2004, and the verdict has come in 2023, January this year, which is about 19 years after the complaint. The next case, in which the pre-anesthesia check was deficient, the case happened in 2008. This is a 66-year-old female with fractured forearm. She was operated in the morning, but the patient did not regain consciousness. She was later intubated, put on ventilator, and died without regaining consciousness after 4 months. And the diagnosis was hypoxic encephalopathy. Now, when the National Commission investigated, it was found that the pre-anesthesia check was not done properly. The hemoglobin of 7.4 was missed. The anesthetist had given ketamine 5 ml, Fortrin 25 milligram, compost 10 milligram. And it was, the complaint was that the ketamine dose was excessive. And also the National Commission realized that at the critical event, another intensivist had to be called to assist with intubation. And it is probable that the delay was has caused the hypoxia. Along with that, there was no record of intraoperative monitoring. Now, the anesthetist unfortunately died during the pendency of this matter, but the hospital and the surgeon was held liable for not following the normal SOPs, and 10 lakhs has been awarded as compensation. Now, here again, the case happened in 2008. The verdict has come in March this year, 2023. Consent is always, kind of any deficiency in consent is always litigated. This is our famous case from Mumbai. This is a doctor versus doctor case of Dr. Amit Maide. The patient was a surgeon, and the surgeon said that no formal consent was taken, and the risks were not explained, and the defendant could not produce a consent which was signed. And this was held as deficiency of service, and more than 12 lakhs has been awarded. Another case from Pune, a patient underwent mitral valve replacement, and the patient's mother said that the consent was not taken and the risks were not explained, and 11 doctors have been booked for an improper consent. And this happened in January 2019. In this very interesting case in Calcutta, the patient undergoes an angioplasty, and post-angioplasty, he dies. Now, they could not find any negligence, but the patient's signature, the date, and the time on the form have been left blank. No risks have been documented in the consent, and the doctor's signature is absent. And 3 lakhs has been paid, has been awarded as compensation, with 25,000 as litigation fees. So you can see what small things or deficiency in the consent can bring about a liability. Now, there are other consequences of an improper consent. Now, in this case, a transplant surgeon did not document a specific consent for a pancreatic transplant along with a renal transplant. Also, there was no signature of the competent patient, only the daughter had signed on the consent form. Now, this transplant surgeon loses his license to practice for 1 year in the then Indian Medical Council Act under Chapter 7. So this is also a serious problem if the consent is not proper. In an emergency, they say consent is not required. In fact, you may be liable if you wait for a consent to save a life or limb or stabilize a patient or to prevent documentation. But that does not mean the other documents are not to be filled. So documentation of the emergency is definitely required. Now, what is the legal status of a death on table consent? You know, there are lots of people who write death on table and try to take a consent. Now, a death on table consent is bad in law because we have to take consent for the hope of life, not for the certainty of death. So a high-risk consent mentioning all comorbidities, the likelihood of critical risks like cardiac arrest, cardiac failure, respiratory failure, and not getting, need for ICU ventilation is usually enough. Because asking a patient to sign his life away is not considered good in law. Dr. Kulkarni has already talked about this, about the safe surgery checklist. This is a document which I think every anesthetist must, put along with his preoperative, along with his intraoperative record. Here in 2016, in Fortis Hospital, actually, the patient was operated on the wrong side. And well, you can see the consequences that the hospital staffers were, of course, sacked. And not just that, the Delhi Medical Council has taken suo motu action on the doctors, and they may lose their license to practice for some time. The other important aspect of intraoperative documentation is to document all the monitoring that we are actually ensuring. In this case, a patient who was to undergo a laparoscopic removal of a benign tumor suddenly has a collapse and dies a few hours later. The diagnosis of carbon dioxide embolism was made by the anesthetist, but there was no document to show any monitoring of the end-tidal CO2. The other documents also failed to show that diligent efforts were made after this embolism and what treatment was given. And this was held as negligent by the Gujarat State Commission, and both the doctors, the surgeon and the anesthetist told to pay 33 lakhs for the patient's death. A physician was called at during the resuscitation phase, and also the physician did accompany the anesthetist to a higher center, but he has been absolved from from negligence. So what kind of documents should be, we should do if there is an adverse event? So we have to highlight the diagnosis or the differential diagnosis. We must highlight all the monitoring that was going on. We must highlight all the drugs, equipment, and the treatment that were available and used, especially the defibrillator, and the treatment which is given on the current accepted guidelines and protocols. And also we must mention all the information given to the patient, usually the relatives, from time to time. Now, in this case, this is a 2018 case from Apollo Chennai. A 29-year-old patient was just to be examined under anesthesia for post-hemorrhoidectomy pain. In the recovery room, he had a cardiac arrest. Later, he developed multiple complications and died. Now, in his documents, the CPR notes were not written, and this was hailed as res ipsa loquitur and deficiency of service. And look at the payment or the compensation awarded by 4 parties. This is almost 57,64,000 to be paid by the surgeon, anesthetist, and the hospital. Now, this is the case that has made the headlines in the last 2 days. 2010, a patient walks to the hospital for a cesarean section. The anesthetist chooses general anesthesia because the patient has a spine problem. Before the surgery starts, the patient has a cardiac arrest and dies a few hours later. The documentation by the anesthetist shows that the cause of arrest as anaphylaxis to thiopentone sodium. The husband insists on a postmortem. Now, in the postmortem, they find a fracture of the sacroiliac joint with 1500 ml of blood with clots. Also, they find 200 ml of blood in the peritoneum. The anesthetist, the National Commission actually has brought out this ruling. They have said that the anesthetist failed to explain the cause of this traumatic blood loss and the fracture. It obviously cannot be because of anaphylaxis, and was there a fall from the OT table. The other thing that they have noticed is that in the documents, there was no attempt at trying to save the baby. Another thing that they have noted is that the forensic lab, which took all the hard disk of the OT monitor, the ICU monitor, and the USG machine, all the data had been deleted. So this is, they have said, is destroying evidence. And look at the payment. This fabricating of documents, 1.5 crores has been awarded against the hospital as vicarious liability, and 10 lakhs to be paid by the anesthetist. Now, this anesthetist, I would just like to also inform that in, I think, 2010, when they were investigating, the Karnataka Medical Council also found that the anesthetist was not registered. His anesthesia certificate was not registered with the Karnataka Medical Council, and he had already lost his license to practice for some time. Another dangerous thing about documentation is to see contradictions in the case record. Now, in this case, which happened long time ago, but I like to use it because there was a total contradiction in the anesthesia record and the surgical record. So the anesthetist said that the patient was stable and I have given preoperatively, and I have given spinal anesthesia. And the gynecologist says that the patient was unstable and it was an emergency, and that is what she has written in her case sheets. Now, at postmortem, they found that 2 liters of blood were there in the abdomen. So now what happens is discrepancies in the obstetrician and the anesthetist notes makes the courts suspicious, and usually both are held negligent. Now, there are some other important legal aspects of medical records. They could be physical or electronic. And the first thing is that medical records, whose property are they? So now the settled principle is that with the physical or electronic records, which are generated by the healthcare service provider, are held in trust by them on behalf of the patient. The contained data in the record are protected healthcare information is owned by the patient herself or himself. And that is why the patient can request for medical records at any point, and this request has to be duly acknowledged, and the documents must be issued to the patient within a period of 72 hours. Confidentiality is an important part of a legal problem. The patients expect that their doctors, lab technicians, nurses will keep what they find, information that has been shared with them, they will keep it just to themselves. Now, in this case, an anesthetist was sharing the C-section photos of triplets being born. And this was held as an assault to outrage modesty under the criminal IPC section 354. It was also a violation of the IT Act 66E and 67A, which is voyeurism and publishing of private images in the media. So one must really refrain from discussing so-called interesting cases in corridors and cafes, because we could be held as, violating confidentiality. Similarly, telecasting live procedures, displaying photographs, videos, audio recordings in conferences, presentations, and media without the patient's specific written consent is a violation of confidentiality. And here the Sri Chitra Institute has been awarded a lakh of rupees as a fine. Now, we are all now entering a rather new era of electronic medical record, and it has to be an inevitable change because preserving physical record is just unsustainable. Look at the volume of data that we generate, especially NABH, for NABH accreditation. Now, retrieval also of medical records is also very, very difficult when it is in the physical form. There is loss of content due to ink, fragile nature of the paper, and human factors actually leading to incomplete records and poor handwriting also, create a lot of legal problem. Storage space, which is required to keep these records safe, is also a real challenge. So now the electronic medical records will now become a part of the digital health data of the patient. Now, we all have to be really careful about what we are doing, because now the hospital, because for their admin purpose, they are collecting patient identifying information. This could be name, address, telephone number. There are so many people, so many hospitals which take bank account, credit card numbers, PAN card, passport number, voter ID number, fingerprints, and biometrics. Also, the healthcare professional or the doctors, we are collecting sensitive clinical data. This could be the physical data, mental health, investigations, organ donation, blood donation, photographs, which are clinical, video recordings of consents, printouts from monitors, equipment, especially in the ICU and the OT, email, text messages sent to patients, both outgoing and professional coming in from patients, correspondence between healthcare professionals about patients, notes made by the secretary about patient and patient billing details. These are all held as sensitive data. Now, the healthcare provider or the person who collects this data has to ensure patient privacy of this data. Now, patient privacy means that only the patient has the right to access their data. All disclosures or use of this data can only be done with the patient consent. Then the patient has to actually choose to either anonymize this data, which means totally remove the patient identifying information from this data, or which you would like to do if you are using it for research, or de-identification. That means removing patient identifying information for a short time to be used for any other clinical purpose. Now, the records which are made electronically have to be compulsorily preserved and not destroyed during the lifetime of a patient, that is, like ever. If the patient has disease, then you have to make that data inactive, but you cannot destroy it. Another problem is that the healthcare service providers have to ensure safety of the patient's digital health data. So all health-related information is sensitive. If it gets compromised, lost, exposed, it can cause harm. It can be used to threaten, extort. It can be used to cause violence, discrimination, and embarrassment to individuals. If this leak is traced to our storage computer or our website, we are liable. And now the next slide is probably the most important slide, and that is that the health care data is the most sought after by cyber criminals. Here you can see that this is the payment that they will get for financial data, that is $245 per data, per single data, and $380 for healthcare data. So you can imagine how much the unregulated health data from India is like a gold mine for cyber criminals. And you can imagine the amount of safety restrictions that you have to put on your electronic medical record if you want to keep it safe. Now, already the cyber criminals have started targeting Indian healthcare sites. And this is August 2019, theft of data of high-profile Indians from a healthcare website. This was actually quite shocking. Anyway, unfortunately, we have very, very meek laws which take care of infringements. We have an electronic health record which has been upgraded in 2016 by the Ministry of Health and Family Welfare, and we are yet waiting for DISHA, that is the 2018 digital information security of healthcare to take off. So while India is now integrating a national digital health program, and we are entering a new era of digital health records, the cybersecurity is going to be our biggest challenge. And you can imagine the infrastructure that is going to be required to keep all this data safe. So let me conclude by saying that documentation of the details of our dialogue, discussion, and intervention makes medical records into a formidable defense. And let all our excellence in medical care reflect in our documentation. And thank you very much.
Thank you, Madam, for the excellent up-to-date presentation. I request Dr. Venkatgiri sir. Sir, are you there? Venkatgiri sir? Okay. Kalpana Kayakar madam.
Yes, yes. Pratibha, it was an excellent talk. Absolutely excellent. But I have some doubts. Now, in these today's days of our communication, it has become so commonplace to sort of post information on WhatsApp, like all the clinical laboratories, pathological laboratories are sending us the mail regarding our health checkup or WhatsApp message. So, do you think that whatever last 2, 3 slides you showed, is it dangerous from that angle, and should it be discouraged?
Actually, WhatsApp today, they are saying that it's encrypted and nobody can, kind of go there. See, we have to look at it like this, that is somebody going to try to, kind of infringe on your privacy? They can. Let me tell you, our data is all over the place. I
Yeah.
mean, this is a fact. Let us not, kind of make any bones about it. We are careless, and it is everywhere. Madam, wherever you go, they say first put down your PAN card, first
Yeah.
put down your thing, and send it on WhatsApp, send it on a message. How can we stop it? So
And even what you
basically,
said, that if that thing is traced to our record, then we are liable. Like if we
no,
are
so
having,
now see, now if I release my, PAN card details or some details to somebody, that person has to keep it safe. It is, I have released mine, but if I'm collecting, like I am, kind of taking consent from patients on video, on my phone,
yes,
okay, how do I keep it? So, video consents and all this looks absolutely fine. But unless there is an infrastructure to keep all these things safe,
yeah,
one
that's
has
what
to
I mean. That
really
it is
look at.
really frightening. It is
It is
absolutely,
tricky. It's
yeah,
tricky. I don't know if see, all hospitals today will have to invest in infrastructure. Actually, see, even the recording that we are doing right now, where does it go? We
yeah,
really don't see. All
yeah,
our photographs are there. We are talking sensitive information. Where does it
yeah.
go? We are really not bothered.
Bothered. Yeah.
So,
So
see, it's all, I mean, it's our Indian mindset. Let's just put it that way. And we are very careless.
yeah,
And
because
it
you
does not,
see,
but
now I'm in critical care medicine. So even post-operatively, the residents keep on informing us. Even in anesthesia, the residents keep on informing us on WhatsApp. Okay, what has happened? So it is so dangerous. That means, do we have to delete all that conversation?
see, every conversation, if the court wants it, can be retrieved.
Yes.
Every conversation. Okay.
No, the court can
So,
retrieve, but what about the cyber crime? I mean, can somebody else use it and then? you know.
So today, okay, you can file a case against WhatsApp. You know, if you feel that sensitive data is getting, because today what we are doing on WhatsApp or what industry is doing on WhatsApp is because they are ensuring end-to-end encryption.
Yeah, yeah.
So that is why. So even insurance companies which were otherwise not sending us anything besides mail have started now. Banks.
Yes.
Okay, so whether we should really bank with WhatsApp, I mean, is your own personal choice. But it's so convenient. So you want to do everything that is convenient.
So there is a danger, isn't it?
Yes.
Yeah.
So the reason why I put up this is that, don't take it lightly.
Yeah.
Don't take it lightly. It is more important to judge whether this conversation needs to be, kind of recorded, or does it really need any, kind of evidence? Is there any other way of keeping it safe?
Right.
Even they are
Because
stealing digital
infrastructure
information.
and cybersecurity is going
Yeah.
to be the next thing that takes all of us by shock.
Yeah.
They are stealing our digital information stored in our computer, server,
Yes,
electronic devices.
yes.
Yes, for their financial gain only.
So for us, for convenience, whatever we are using, we have to take it with a pinch of salt. And
Just
we have
take
to
it
be
in the
wiser.
sense that
Yeah.
just be aware where you
Yeah.
are, kind of disclosing, especially if it is patient data related.
Yes.
If you see our admin, actually, because the patients are in such a gullible state, ideally, they should really not take every information from them. But it's all there and it's all on the computers, which
Yeah.
I don't think that the hospital computers of the reception has got any, kind of
Security. Yeah.
security.
Because
Yeah.
that information can be stolen by anybody.
Yeah.
Yeah.
I mean, you can sit and steal it, madam. You
Yeah,
just sit
yes,
over
yes.
there for 5 minutes, take 2 photographs, and you're done.
Yeah, yeah. And very
So we
nicely
are
covered.
taking it.
Yeah. Very nicely
Madam,
covered talk.
how many years we should keep the hard copy, that is record in hard
See,
copy?
if there is a legal issue, hard copies 10 years.
Okay.
But
If
the
there is
legal
a
issues,
case, because you can see that every case is going for 19 years, 20 years. So medical legal, if there is an issue, just keep it, scan it and keep it, because then at least, the physical form is not a thing, but the scanned copies you can keep quite nicely. The other thing is that otherwise our Indian, the medical councils are saying 3 years. If there is no other problem, 3
but
years.
for how
But
long?
on the safer side, 5 years. Yeah.
For how long can a person go against the doctors legally after completion of the case? I mean, that
See,
will
if it
decide.
is nowadays, well, it was 2 years. Okay.
Yeah.
So limitation period is 2 years.
2 years
But
is for civil. Criminal,
for
there is no
civil,
time
that's what
limit.
I'm saying.
Yeah.
So criminal, the minute anybody can
Yes.
just, kind of get up, and the courts are allowing it. They just get up and say, now I feel that, that time something has happened. And it is now exploding into something
So I
quite
think the digital
dangerous.
records must be preserved forever. Because in the
So,
digital
no,
format,
the minute you have electronic medical records, you
yes.
cannot destroy them. I told you that.
Right.
You cannot
Yes.
destroy them. Because you will have to, if that person goes somewhere else, you have to transfer them. And you are responsible for transferring them safely.
Yeah.
So it is a big, I mean, I really don't know. It needs a lot of stringent laws. In America, data is like the most valuable thing that you can have. And data is protected with very, very strong laws, which
The time the
we
problem is 2 years from the cause of action, we have to keep the records. That's what says. But what happens is, suppose sterilization failure, when will you know? Only when it fails. So you can't say that, no. See, it is after 3 years she became pregnant. Then 2-year act
So
doesn't come
that's
there.
what I'm saying,
There's
that you have to
limitation.
preserve
So
it
you may have to
forever.
sometimes keep it long. See, if it's a PPS failure, she becomes pregnant only a 5th year. You can't say that limitation time 2 years over and all. But her course of action is the 2 years back. That's why we have to be very judicious, because we are always at the receiving end. They are at the receiving. So we have to be careful, medico-legal and even otherwise also. Sometimes patient, the court is lenient. They say that I didn't know that. I came to know only now. I didn't. Now the cause of action. Some complication, if you have put some implant and that came to know only when it was removed or this thing. See, in that case, we can't do anything. These sort of things. But we have to
Generally,
keep it
for
open.
anesthetists, mostly we do come to know in the perioperative period. So,
for
so
ours it's not
implants
that, but
and
in the
stuff like
general
that, usually the anesthesia related things will come up in the first 2-3 years. Yes, Dr.
That's
Kulkarni,
fine.
yes, you wanted to ask me something.
So, one comment, ma'am. Basically, essentially, what is happening, as you mentioned very clearly, documentation is very, very important. There's no doubt about it. And there's a limitation how much you write. Nowadays, what is happening is that patients coming to the surgeon or even for anesthesia preoperatively, first thing they enter and they take out the mobile and keep on the table and they start talking to you. And their voice recorder is on.
Yes.
They are recording all your conversation.
Yes.
Now, you might say that, if a phone comes or the rings, it will be this thing, but there are ways around it. They put on airplane mode and put the recording on, so no phone can come. So they're recording all the conversation. And so it's probably high time that, in either in hospitals or at least for high risk ones, you need to have a video recording of the consents, everything, which would really be important to do nowadays. And it's not very difficult to do, isn't it? I mean, to have a system, to have a video recording preoperatively.
But the problem is,
Yes.
where does all this get stored?
Yes.
Will it get retrieved? Is it safe? See, that is the issue. And let me tell you, if the what do you call it, a patient records, okay, there is a rule now, whether it we abide by it or not. But if you take a recording without the other person knowing it, okay, you cannot use it. You cannot use it. And the main issue is that is why whenever we are doing webinars or anything, they say recording is in progress. That means already you have consented, when you are continuing with this webinar, that you're consented to recording. So these are very small things, but they are important, that you just go to any person and say, okay, I'm recording. You have to take a consent for release of that recording. Or if you want to take from the thing, then you have to, when you start, the telemedicine guidelines give this very,
Yes.
very clearly. So what they
Even-
are saying is that if the patient calls you, that is an implied consent. If you call the patient and record, okay, you have to actually say that you are actually being recorded, and we continue.
Even you.
So these
you
are 2020, the telemedicine guidelines are very clear about all these issues.
Even you are taking some photos, there should be a noise or click or some sound should be there when you are clicking the pics also.
Okay, all right.
On a
Avinash,
lighter
there are
note,
two questions in the Q&A section. Avinash sir,
Yes.
there are two questions in the question answer session.
Yes, just read it.
Why there is the first question is, while doing high risk cases, many times we forget to put some keywords in high risk consent. Can we rewrite it during surgery as we recollect some missing things in consent? In change of is change of writing material like pen or ink acceptable while dispute arises? This is the first question. And the same person has asked another question. Many times we do share cases like due to shift of duties, do we need to have sign of both anesthetist on consent or sign of anesthetist starting the case suffice? These are two questions by the same person to Dr. Kane madam.
Who are they addressed to? I mean,
Kane,
anybody.
to you.
It is addressed to Dr. Kane madam.
All right. Okay, sorry. All right. So first thing is about I think 2 anesthetists, right? So if you are, see, anesthesia practice, if you're doing in a kind of a team, that team needs to get introduced at the time of consent. And the fact that intra-op, if you're going to have a change of anesthetist, any surgery going on for a very long time, it's better that both of y'all are identified at the time of consent, because these are all high-risk surgery. If you need 2 anesthetists, either for a short time or for a long time to take over, it is always best to tell the patient there will be 2 people, or I will be leaving at whatever time, and a proper handover. Even in your documents, you have to say that the case has been handed over to doctor, whatever, and the vitals at that time. And the person who takes over can sign over there and say that received. That is one. And what was the other one?
Yeah, the question is,
okay, making
during
corrections,
high-risk
corrections.
cases,
Yeah. So
correct.
it is, yeah, I know there was one case when an adverse remark was made because of change of pens. Okay. But see, you cannot stop every litigation. Okay. What you need to do is, from a point of view that you remembered something, whatever time you remembered, just put the date and time. Okay. So you're not trying to, kind of fabricate the document, but you're just trying to add to the value of that document. I think, and it really doesn't matter the pen or whatever. But yes, there is a case where the state commission has said there are 3 pens being used. So, who is giving care? But I think we don't have, you just have to go with the whole essence of what they are trying to say is that a responsible person has to be there.
The first part, yeah, madam, the first part of the question was regarding the keywords in the high-risk consent.
Yeah. So,
can I read that again?
don't add in the high-risk consent, not in the consent.
Yeah.
No,
yeah.
no.
What do you have consented?
That was the point asked in that question. Can we add or in this rewrite that high-risk consent? That was the question asked in the.
Okay, I'll be very honest. There are lots of things that I do add in high-risk consent, but if you have taken, whatever you have written, principally, you cannot change. Okay. So if you've not mentioned ventilator, the patient, see, half the consents are because risk was not mentioned. This risk was not mentioned. Okay. So, but not that every consent will be held against you, but best not to tamper with consent. And see whether half our patients don't read the consent. You can have a 5-page consent with everything written on it, and Dr. Kherkar knows the patient will say, I didn't have time to read it. I didn't have time to understand it. So if anybody wants to find faults with your consent, they can. Hai na, madam?
Hai barobar hai, but there was one judgment where it was, you also were there for that meeting, where there was this thing given that every time the consent has to be handwritten. It cannot be a form.
No,
So
see, there is this case. This is the case of RG Stone Company, okay? And this was Dr. Kantikar from National Commission, who has said that printed consent forms form a part of unfair trade practice, okay? Now, this is totally in sub judice now. It has been it is yet under, there is a stay on this one. And see, it is not possible. But yes, our consent form should not be fully printed. There should be some area where you can individualize.
So
the
that is
risks.
what that person is asking. That sometimes it can so happen that before starting the case, the person
No,
has
he
taken a
has
consent.
he has made a
Yeah.
comment that just
Yeah.
writing a few words
Yeah.
is not enough and all. But if you really look at it practically, nobody can sit and write even one-page consent. It's not possible.
And in that, then it is very likely that we omit some things and then we recollect them and then we want to add them. So that is what the questioner has
So
asked.
what I
And-
feel is that whatever risks that you mention, you just say patient counseled about these 2, 4, 5 risks. And you must never put any kind of get any consent signed without putting either nausea, vomiting, headache, something, some risk must be told, because there's no anesthesia without risk. So even if it's an ASA grade 1 patient, for spinal anesthesia, say headache, say, nausea, vomiting.
Madam, with the
Yes,
change
sir.
of the
Madam, should we,
surgical plan,
one question, madam, regarding this only. Should we sign every time when we rewrite or we add something or we do correction there?
See, better, because
Better.
see, especially if it is a point which is going to be very valid, okay, not just anything, not just putting, but if it is a valid point which you want to be taken into consideration, if at all this comes into any kind of a conflict, then yes, it's always better to take responsibility.
Thank you.
Madam,
Yes, sir.
Dr. Kulkarni sir
as you
wants
said
to
about
comment.
you said about people not reading the consent. We have had patients who were judges themselves, and they also don't read and just sign blindly in front of you. So
I
somebody
know
asked them, basically, don't you want to read what is written? He just laughed at it. He says, I know what it is.
He said, we'll
But he
see
may
you in
also-
court.
Yes, that's correct.
We'll
And
see you in court.
on a lighter note, this was a few years ago, one of the American anesthetists, Indian origin, he just casually mentioned to me, what do I do nowadays because to become from medical legal practice, saying that, I write the paper first and then start anesthetizing the patient. So, that sort of perfect record keeping.
It's become more and more difficult. And see, trust is gone. Unfortunately, whatever you may say, trust is gone. And especially if you see this today's case that I have mentioned, a patient just falling from the OT table and so the trust goes. And that, that case has hit the headlines in 2010. It has hit the headlines in 2012. And just now it has come out in the headlines today. But so our trust is an issue.
I think Dr. Sare sir has joined this webinar. Sir.
Good evening, Sare sir.
Welcome,
Nice to
sir.
see you here.
Good evening. Sare sir.
Yes,
Please
Sony
unmute,
sir.
sir.
Yeah.
Sare
I
sir,
could not join. Yeah, good evening to all. I was unable to join because of the close wedding of one of our partners of the hospital.
Yes, Sony sir.
Thank you, ma'am.
So, I hope the things went very smoothly
Yes,
and
yes, sir.
the faces I can make out Satish and Pratima madam that they are cheerful at the end also.
Yeah.
So,
My God.
Yeah.
No, we have to be cheerful, sir.
Madam
At least
is
here, let
always-
us be cheerful. At workplace, you know how our faces fall.
Let me make some comment on this discussion right now. We are all discussing about documentation, queries related to documentation. But the first lecture by Dr. Satish Kulkarni, let us focus on that part also, which will usually resolve many of the problems. What I feel is the proper communication. So, of course, documents are going to be important in the latter period, whenever the parties go into litigation and consumer courts or court of law like that. But Dr. Satish sir, a little bit from you, I will like to comments from your side about re-insisting on proper communications in the OT staff, with the patients, with the relatives. A little bit from you, sir. Thank you.
I mean, there is no doubt about that. Proper and effective communication is very, very important to avoid a lot of problems. Yes, patients do suffer because of medical errors, which are probably 50% or 60% of them because of improper communication. There's no doubt about it. But as Madam said, the trust has gone. And if you do not communicate, then you are really, really open for litigation and everything. So you need to, with proper communication, which can be difficult, and documentation is equally important because you might communicate. And that's the reason I mentioned about this video consents, because whatever you say, you cannot write everything on paper probably. And whichever, even you might have a booklet of a consent form, it can be torn to pieces. Another very important area is that, patients getting admitted late and they come down to the theater and taking consents in outside the operating theater, just at the door. It just doesn't get valid. Patients can very well say, I was about to open my car and this fellow put the gun on my head and said, sign, give me the keys. I didn't have a choice. And it does stand. Obviously, it will stand. So, having as early as possible the consents, the communication, as well as, as early as possible, preferably 24 hours prior. But, our doing the system, patients do get admitted
Our
late.
systems
they just get
are
1 hour.
most unsupportive for anesthetists.
For everybody,
Most
ma'am, even for the
unsupportive for
surgeons, even for the surgeons. I mean, patients coming late, but so many times they see them in the pre-operative outpatient, but they
Yeah.
don't take consent
So
there.
they've already seen them before. For
But
us,
ma'am,
it
they
is
don't take the
extremely
consent there. And none of the surgeons take consent themselves. Our anesthetists people, we take our consents, but most of their residents sign. And sometimes there are medical officers who take the consents, and patients, whatever they ask, probably, I don't know, they might have been explained before in the outpatient or something. We don't know. So that is the reason probably I feel with all the high risk patients coming in, because all the major hospitals, if you see, you're going to get poor risk patients only. That is why they
That's
come to the
what I
hospital.
meant when I said about the communication. And as Dr.
Yes,
Kulkarni
absolutely, madam.
rightly said, if it is a video consent, even non-verbal communication will be recorded. That is, we being empathetic with the patient, trying to
That's correct.
explain. That also will be recorded and will be a very good defense.
That's what I
Sir,
said.
video
Communication
consent.
prevent- Yes, communication prevent and documentation protect you from the legal issue.
Yes.
And when you, even you have not done it, you just document it. Documentation is important.
Yeah, that is important because Avinash, law says that whatever you haven't written is not done. That is what the stand taken by the court of law.
There is a
So
saying
you
that
have
if
to
you have,
write.
there is a common saying with what we tell our juniors. If you have done it, write it up. If you do not document it, that means you have not done it.
You haven't
If
done
you have done something, charge for it. If you do not charge for it, you are not a professional, you are an amateur.
Absolutely.
The video consent actually works in two ways. I mean, it's like a little double-edged sword. You have
Yes.
to be very, very careful because the
Absolutely.
patients can ask you very, very difficult
questions.
answers, and then your body language and everything. So you have to actually, kind of be a little more, a little drama and all this. You have
Madam,
to
you
be
got to
little
get trained for it. You have to get trained for these sort
trained.
of things, as simple as that, so that you are aware of what likely questions and what sudden surprises they might throw at you,
Surprise.
and how you're going to
So-
answer, what sort of words you're going to use, what sort
Because
of words
once
you're
you
not
have
going to
agreed for a
use.
video consent, you can't pull it back.
Yes.
Yes, with that video recording, one case was there. They see in that the LACS consent was given at a particular time, and actually the surgeon came after 45 minutes, and then anesthetist come after 1 hour, and they started the LACS after giving consent nearly 1 hour later. So it goes against the hospital also.
It depends on the situation. If it's an emergency, elective, multiple things will come up. As Madam said, it's not a double-edged sword. It's not as
Yeah.
easy as it appears. It's very nice to, but at least in elective, major, where the costing is very high, say
Elective,
liver
major,
transplant.
transplant,
Absolutely.
because then you can have a set of,
Absolutely.
risks and set of thing. So little bit of rehearsed
Absolutely.
stuff can go in.
Yes.
Okay. Thank you
right.
very much. I
Basically,
think,
I
yes,
will
sir.
just a minute. Basically, now Kelkar madam is here. She must have reviewed lot of incidences across Maharashtra, wherein a lot of review cases. Whenever there is a any police complaint, she must have reviewed in BJ Medical College. Kane madam being an expert from the legal side, they have reviewed. And almost I was one of the in those days in 90s in JJ Hospital. I used to be a secretary for this review committee where 12 members were there. What we find is the document everywhere. Whenever the cases used to come in the for the court of law, it is the documentation. What was lacking most of the time, everybody does some or other thing, something is missed, but documentation plays a major role. That's what I feel in the court of law whenever it
Absolutely.
stands.
Absolutely.
And secondly, our infrastructure, even though we are working in the corporate hospitals or government hospitals, major hospitals, I mean, civil hospital or medical college hospital, where is the infrastructure to take the video, audio consent?
Absolutely.
And forget about the corporate hospitals, even 70%, 60, 70% practice of anesthesia is going as a freelancer. The 15 bed, 20 bed, 30 bed nursing homes are there. What facilities actually patients are consent? Consent घेतली का? घेतली चला गेल्या की दिला spinal लावला आणि
Nobody
हात
checks.
चालू झाली. People are lacking. So I always insist whenever the situation comes, your pre-operative evaluation is very, very important, and the consent, and that to informed consent, anesthetist has to learn to inform the patient all the aspects of that this thing. What anesthesia is giving,
Absolutely.
if that is good. This is where we are really lacking.
Okay, thank you, sir.
Thank you so much. Thank you.
It's already 9.
Yeah.
10. I think we will stop here.
I just took
With
the
your
opportunity
permission.
that still it must be going on. As soon as I entered, just parked the car, and I thought that I'll join immediately.
Nice.
Yeah,
Thank you so much.
Thank you for joining, sir.
Avinash
Yeah.
sir, few comments from Dr. Venkatgiri sir, if he wants to make some comments before just we conclude this.
Yeah. Kane madam also spoke well. As Sir told that what court says, what is written is believed, not is what you have heard or so. So whatever you do that, you have to document. The court doesn't believe anything which you say that.
Sir,
You
your
can't
voice is
remember
not
the
clear, sir.
afterwards. So in many medical records, whatever you do, it should be documented. That is the most important thing. Court doesn't say what we have to document, whatever we do. That is the most important thing. Second thing is, as she said that record.
Sir, your voice.
And how long we have to keep. That depends on what type of case. It's not audible.
Yes, it is not clear, sir. It is interrupting.
I will come to that again.
Hello.
Yeah. Yeah. Is it audible now?
Yes, sir.
Hello?
Yes, sir. It is audible.
Yeah. The most important thing is whatever we do, we should record it. That is the most important. Court believe only, whenever medical legal case, court believe only what you have written. But while writing also, write what my personal advice is, write minimum, do not write other unnecessary things. Many times that lands in trouble. What is basic required, we have to write. Because in my own experience, I'm telling, I went as an expert in a case. The anesthetist has written the spinal, she gave for a hernia surgery T4 level. It's essentially T4 or T6. In the panel, the forensic surgeon, he asked me, Doctor, you require only T10 level for hernia surgery. She has given up to T6 level. Patient has respiratory distress. That is the cause. Why did she give to T6 level? We can't help our colleagues also. She has committed, so whatever required, you have to write. Don't always write whatever you do that, what is required, yes, we have to write. But T6, T4 and all, if you write that, okay, she tried, then and wrote that, he immediately and ask me, is it right? I can't tell anything. See, then they're asking, Giri being our colleague, he could not support me. We can't. These are things many times we have to do. Whatever is required, we do that. Many unnecessary things, please don't do or record. That is what is required.
Okay.
Okay.
Thank you very much,
Excellent
sir.
talk by both. Again, it is. We can hear if it is in the YouTube. People can again log in and see that and learn from that. Whatever is required. Excellent.
Okay, thank you very much, sir. We'll conclude this session now.
Thank
I
you.
thank Dr. Venkatgiri sir and Dr. Kekar madam for giving and us very important inputs in this session. I also thank Dr. Satish Kulkarni sir and Pratibha Kane madam for their excellent lectures. Thank you to the
Thank you very
clear.
much. Thank you very
Thank
much.
you.
Thank you
Have a
all.
good
Thank
evening.
you.
Bye-bye.
Thank you, sir.
Thank you.
Thank you.
Thank you very
sir.
much.
Next month,
Good night.
next month, last
Good night.
Tuesday. We'll meet
Yeah.
again
Thank
next
you.
month on the last Tuesday.
Bye.
See you.
Okay.
Bye-bye.
Thank you.
End the meeting. Ankita, you can end the meeting. Stop recording.
Ankita, stop the recording and end the meeting.
Thank you so much, sir.
Okay. Thank you.
Thank you, sir.
Chalo.
Thank
Bye-bye.
you, Avinash.
Thank you, sir.
And get the recordings at the earliest to us, Ankita. Make it
Ankita.
available to us.
Ankita.
अब बंद केलं ते ना.
Hmm.
चलो बाय.
Recording चालू आहे अजून.
Ankita, the recording has to be stopped now.
Yes, sir. Yes, sir. I will stop the recording, sir. Sir, with your permission, can we end this
And-
session here?
And end the meeting now.
Yes, yes.
And
Thank you
make
so much.
the
Good night, sir.
link available tomorrow only.
Okay, sir. Sir, you may all leave, sir. I am ending this session. Good night.
Okay. Good day.